Good afternoon, good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing covers health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Management Lead at IMST based in DRC. We are also joined by other Africa CDC experts on this call. I will now hand it over to Professor Yap to start the session. Over to you, Prof.
Good morning, good afternoon, good evening. Thank you, Dr. Margaret, for giving me the floor. So apologies from our excellent DG, Jean Kaseya, who is meeting the president of Mozambique as we do speak. And then I'm going to present on his behalf. So I will thank all the journalists who are the catalyzer of all the great work that our colleagues are doing in the field. Churchill mentioned that we should never lose an opportunity of a good crisis. And definitely, we have quite a number of crises happening in the continent. So we are taking it as an opportunity to rethink, as you will see during our presentation, how we want to finance the response to those outbreaks and how we want this outbreak to provide a legacy for the member state on how we will prepare and respond to the upcoming epidemics. Over to you. Thank you. So as we mentioned, we are in a very volatile era. We are all aware of the challenges on the freeze of funding coming from different countries. This is an opportunity for the continent, and Africa CDC is really pushing the rethinking of African health financing in this new era. So we just launched this new concept paper, and I invite all of you to have access to our website so that you can download this piece. And we are looking at three critical pillars. The first one is how countries can mobilize more domestic financing and alignment of the external fund. This is within the idea, within the concept of the Lusaka agenda. The second pillar is the more innovative financing to support country to respond to those outbreaks. And when we think about innovative financing, we are thinking about the support from the diaspora. We think about the taxes that can come from the air ticket, all those opportunities that we can leverage to get extra fund for our countries to respond to those pandemics. And the third one, it's an invitation of a stronger partnership with the private sector. We are thinking about a more blended finance for appropriate investment to address financing gap that we see currently and in the future for health security. But all that has to rely on a critical anti-fraud, anti-corruption measure to allow efficient allocation and use of funds, pool procurement to the APPM, the digitization, and of course, to monitor the impact and ensure the sustainability of those investments. So those are the three key pillars with the cross-cutting pillar that you will find in the concept paper, and we really engage you to read it, to share it widely. Next slide. Now, still moving to find those alternative funding. We are moving, our Director General, Dr. Jean Kaseya, is championing the local manufacturing agenda. Last week in Abu Dhabi, leaders, global leaders, were meeting to see how we can make that concept a reality. A lot of initiatives started during the COVID, but we really want to accelerate them. And he's meeting, as you see, the UAE Ministry of Health and Prevention, the CEO of CANEP, but also the Prime Minister of DRC. So you can see the range from the funder to the beneficiary to ensure that the agenda of local manufacturing will really become a reality in the continent. Next slide. that has to rely on a strong institution. And Africa CDC is empowering the National Public Health Institute, which they are all meeting currently in Mozambique, to ensure that we see countries having the proper organization, institution, and framework to build a resilient health system. So quite a number of countries have already made the journey, others are still on the way, and we want to encourage all of them under the leadership of Africa CDC to make sure that every country has its own NPHI to lead and to respond to outbreak, as we are seeing in different countries, as we do speak today, as one example in DRC. Next slide. Last week, we are seeing, if necessary, new impact of the climate change. In DRC, where we currently are responding to the Mpox, there has been torrential rain that occurred between the 4th and the 5th of April, and this led to thousands of displaced people, but also death, 36 deaths in Kinshasa. So that implies several challenges in terms of access to health center, in terms of population not having houses and where to stay, but also several roads were cut. And we also experienced widespread power and water outage across multiple health facilities in Kinshasa. And this is not happening in DRC. We also see in Malawi, in Mozambique, where we have those cyclones that lead to the displacement of 300,000 of displaced persons and 66 deaths in 2025. And the impact of those flooding, you have the acute when you have the people who are affected and the death, but you also what happened later on. Those cholera and other diarrheal disease, the dengue, the malaria, and other vector-borne disease, but also the fact that it limits the way we can respond to the other outbreak, including Mpox, as some of the health centers might be affected. And then we might not be able to deliver or to track the suspected case in the community. Next slide. Now, going back to the situation of Mpox in the continent. Unfortunately, we see that the number of cases are still increasing. Whether we are talking about the suspected case or the confirmed case, we see some increase. And we have an average of 3,000 suspected cases weekly in 2025. And more critical, we go beyond the bar of 50%. So in 3 months, we have already had more than 50% of the total number of cases that we had in 2024. And as you will see later, this is even an underestimate of the reality in the countries. Next slide. When we take the situation of DRC, which has for long been the epicenter of the Mpox, you will see that the number of cases, suspected cases, are quite stable. Number of confirmed slight increase. But what is important to highlight, as we've been mentioning on and on, the low testing coverage. It's around 21%. This means out of 10 suspected cases, only 2 of those will have a sample collected and a test being done. So what we are reporting in terms of confirmed case, it's really just the tip of the iceberg. So if we see that we have that big number of confirmed cases remaining, this represents maybe 10%, 20% of what is really happening. And this happened despite all the efforts that are implemented in terms of laboratory decentralization. So which means the emphasis, the impact, the resources has to be supported more on the sample collection, transportation, and all what is around the surveillance. Next slide. As mentioned, we are carrying on the decentralization of the testing. So as we do speak now, we have 26 testing laboratories with 3 performing qPCR, while in the beginning we were having only 2. This is the one example of DRC. And at the end of the outbreak, we really want to have 56 labs being able to detect the Mpox. But as we mentioned, this is not enough because only 2 out of 10 suspected cases are being tested. So the lab decentralization is great, but we need, during this intensification phase of our plan, to emphasize more on the surveillance and the active tracing. Next slide. Now, Uganda is really challenged, not but also outbreak that I will present, the Crimean Congo hemorrhagic fever that is going on. Besides, the challenge with resources, because local response resources severely colleagues from Africa CDC, for MST and other are on the ground with all the different partners to ensure that the support we give to the country is really adapted to the needs. Last week, we had a meeting with the team on the ground, the incident management team of Uganda, and they re-emphasized the need for support in some very specific area. Next slide. So the good news is that Ebola is really being controlled. We are at the day 26 out of 42. So around the 26th April, if all goes well, we should be able to declare the end of this outbreak. Next slide. So while the management of Ebola is really a case study in Uganda, considering the low case fatality rate, the good practice on tracking the contact and so on, Mpox is a different disease, therefore a total different approach. As we do speak now, Uganda is beyond DRC and account 50% of the case from Africa in the last 6 weeks. This is striking. We also see that in Uganda, the high number of deaths is due mainly to people who are having comorbidity, which emphasize the need to integrate the response of Mpox with HIV and other comorbidities. Next slide. So as we see, and as we are talking with the team in Uganda yesterday, sexual network remained the key driver of the outbreak, which means that the way Uganda is responding to the outbreak will be different to what is being done in DRC, to what is being done in other countries, because they deal with different reality. Now the cases are spreading in slum, in semi-urban and urban city, Mbarara city, Masaka, now account for 50% of daily incident week, while some week ago it was only in Kampala, for example. The good news, we need good news. The vaccination. Uganda have just received an additional 100,000 doses of Mpox vaccine, thanks to all the partners who have played a substantive role on allocating the vaccine and all the logistics to ensure that the vaccine arrive safely in Uganda. And as soon as they arrive, in less than a week, 20,000 persons has been vaccinated. This highlights the demand and the high absorption rate of vaccine in these countries, which means vaccine, though it's not a silver bullet, it's definitely a key tool for Uganda. And they are really taking it as the key strategy for the response, but not the only one. As mentioned earlier, the emphasis also has to be put in the surveillance, the IPC, and the case management. Next slide. So in terms of that integrated response that I was just talking about, the training is a critical component. They've realized that the management of patients in Mpox treatment center was a big challenge due to the high number of patients. Therefore, they moved quickly with the support of IMST, Africa CDC, and WHO, as you can see in those pictures, on training and moving toward home-based care and relying on community healthcare workers, people from the community who can strengthen the case identification, enhance the early detection, and the alert management. This allows to facilitate the response. Now, what they need is to decentralize more in terms of diagnostics so that the time between a suspect gets his result is shortened. Within 24 hours, they need to get the result. Also, all the people around the case, which we call the contact, should also have the opportunity to get vaccinated. If that is done within 24 to 48 hours, then we will be able to break the chain of transmission. Next slide. The vaccine delivery is moving. Yesterday, we were happy at 1:30 a.m. to see 10,000 doses of vaccine arriving in Kenya, which will be a big relief and push the vaccination in the country. Currently, we have 6 countries that are vaccinating. More than 600,000 people, have been administered. 13 countries have granted the approval, but we still need more countries to approve for children between 1 and 12, because we've seen that in many countries, they are also exposed, while those countries have not yet accepted the vaccine to be used in that population, which is the case for DRC, which is vaccinating both the adult and the children. The vaccination has resumed in Uganda, as mentioned, in CAR and also in Rwanda. Next slide. Here, I will pause and thanks all the logistic pillar, all the partners involved, Gavi, UNICEF, all ERA, and all those partners who have made it happen. Over 1 million doses of vaccine has been shipped to Africa. This is not simple. We don't take it for granted. And as mentioned, to see what's happening in Uganda, the high demand, 20,000 people vaccinated within a week, which means within the next 2 weeks or 3 weeks, they may be able to absorb all the doses, and they have already requested extra doses. So our mechanism called TRC will be deciding on how many doses can be allocated to Uganda so that they can control the outbreak. But again, we want to emphasize, vaccination is not a silver bullet, it's not the only tool. Sierra Leone also has kicked off the vaccination, and Africa CDC and partner, we are working tirelessly to ensure that we break all the barriers leading to delays in vaccine shipment, which will pose some risk to expire. Quite a number of countries are suffering, but we are pushing so that in the next few days, few weeks, the vaccine should be available and delivered to the people, the population who are exposed. Next slide. From Mpox to cholera. Cholera is currently affecting quite a number of countries in the continent, but we'll just highlight 2 of them. Angola, where we happily see a decrease, though it's not a big decrease in terms of number of cases, but also in terms of death. And we expect that all the measures that are implemented will push to ensure that that trend carry on. Next slide. In terms of response, vaccination is one of the key pillars. We've seen the vaccine that has been offered by the Africa CDC and ordered by the ICG and the WHO. Now, on top of the vaccination, we need to carry on the support on the provision of alternative safe water to community. Cholera is a disease of poor water. So if the population have access to quality water, then you reduce the exposure, the threat of cholera. And the flooding that I've shown in DRC, in Mozambique, and others countries are opportunities, are risk actually, to have the cholera being spread. That's why it's critical to intensify the cholera surveillance in the 21 province in Cholera in Angola, but also within the neighboring country or all those countries that are affected by the different flooding due to the climate change. And the two last critical support that we provide are on the risk communication and community engagement and the deployment of response team to the province. Next slide. In South Sudan, we can see that it is quite stable, plateauing. And when it's plateauing and we consider the insecurity that is happening in the country, the figure that we are showing, 1,228 cases, 28 deaths, might be actually an underestimation of what is happening. So again, we are discussing with the countries on how we can provide the support with the challenge of insecurity. With what is happening currently in the country, it's difficult to have the people in the ground responding properly to the outbreak. And this is another opportunity, as our Excellency DJ used to send an advocacy to our leaders, because there is no health without peace. Next slide. The visceral leishmaniasis currently happening in Kenya. We are seeing 1,000 cases, 32 deaths, which is quite high. When you have a case fatality ratio of 3.2%, it is quite high. It is happening on the border of Ethiopia and Somalia. And those two countries are the Waji and Masabit, that are reporting the highest number of cases. Next slide. So the continent really continue to face numbers of outbreaks. We've mentioned the Mpox, the cholera, but we need to keep on empower the resilient institution, the NPHI, so that they are the one to carry on the response in their countries. We're happy to see that the number are increasing, and the support of Africa CDC will continue. On top of all the challenge that we are already affecting with those epidemics, the climate change is bringing another layer, which has huge implications on our health. We still have some good news. We have over 1 million of Mpox vaccine doses that have been shipped to our member state, but we need more. In the plan that we have, we aim to vaccinate 6.4 million in the next 6 months. So we might need more vaccine. We might need more support in the member states to ensure a smooth delivery of those vaccines. So I will be now happy to take some of your questions. Over to you, Director.
Thank you very much, Prof. Let's get the first questions from the chat group. We have Flavia Nasaka from Uganda. The question is, now that Uganda is on the countdown to declare the end of Ebola outbreak, what's happening with the Ebola vaccine clinical trial, and what's happening with the therapeutics clinical trial with no one being under treatment currently? That's the first question. Let's take the second one from James Kunda of Anadolu News. The question is, last week, Dr. Kaseya indicated a measles outbreak in Eastern DRC. What is the current status of the outbreak? I'll hand over to you, Prof, for your response.
Thank you. So I will, for the question on the research, I will call our colleague, Professor Musoka, who is connected. Just before John, it's important to have in mind that the research is being done to shape the response to an outbreak, but also to prepare for the next outbreak. Is Professor Musoka online?
Yes, I'm sorry, sir.
Yes. So the question for you, Professor Musoka, was about the Ebola trial that was happening as we are going toward the end of the outbreak. What will come out with the trial and what we can say about it?
Well, thank you very much. So essentially, every time we run a clinical trial in terms of outbreak, we have three main goals. We stop the transmission, we reduce the number of the mobility and mortality of the outbreak, and finally we get answer for the future outbreak. So at least we have two arms going. We have the therapeutic trial going with remdesivir. As we all do know, in terms of Ebola Sudan, there is no therapeutic. What we now have in terms of antiviral is the remdesivir and the MB134, which is the monoclonal. So essential, and then convalescent plasma. The goal is one, at least we've seen it in the beginning that the initial 8 cases were treated with remdesivir and they survived, which is the first objective of the research. Can you hear me? Can you hear me?
Yes, we can hear you.
So we did that. So first of all, we've shown that. The second most important reason is the data we are generating, including now pharmacovigilance data, will help us to see if it is safe and it's efficacious. So the next outbreak, we can go into treat cases. On the other hand, we have the vaccine trial that is going on for Sudan, the VSV for Sudan, that is now used for high-risk contact, which is the idea we want in an outbreak. We vaccinate everybody. We prevent them from getting the disease further, which is the first objective. So both of them will be one. In the event someone gets infected with Ebola Sudan, can the treatment give survival rate? That's the first question I want to do for the future. The next time, if there is an Ebola Sudan, do we now have enough data to show that the vaccine can work? And you and Dr. Yap, we saw the work we did with Ebola Zaire. Today we have a vaccine for that. So they're going to answer the same with Ebola Sudan. Thank you very much.
Thank you very much, Mosoka. It's important to have in mind that there is the time for the response and the time for the research. Sometimes they match, sometimes they don't. And when they don't, the good news is that the research prepares us for the next outbreak. So it's the work that the colleagues are doing. I will talk about the MOSA trial. It's critical, and when we really appreciate all the partners, the Panther, who are really tirelessly making sure that this is happening. So now I will hand over to Dr. Mercy to respond to the question of James regarding the measles outbreak that is happening in India.
Thank you so much, Professor Yap, and thanks for that question. So currently the DRC is at 12,000 cases for measles and over 899 deaths that have been reported across all the 26 provinces. But as you're aware, we really have challenges in getting data, accurate data from the eastern part of DRC. Again, to mention, most of the cases are coming from Equator, where we have really challenges with access to healthcare services, as well as from, of course, these are suspected cases from the conflicted zones. To be more precise, we have most of these children that have been reported, over 80% have 0 doses for measles, just showing that there's really a challenge with getting these children vaccinated against measles. And we are not expecting the situation to get any better if we don't have the humanitarian corridor to get healthcare workers access those hard-to-reach zones to get these children vaccinated. So it's really a situation that we really need to look into keenly, and Africa CDC alongside partners are working to ensure that this happens and we get these children vaccinated. Some of these kids actually are coming, these measles kids. They're coming from the COVID-19, where we had many children that missed getting access to vaccines. And we're also seeing a situation which has been repeated due to insecurity. We definitely are going to see many more children in these areas with 0 dose. Over to you, Prof.
Yes, thank you, Mercy. In this new phase of the response, we are launching actually in the coming days the new plan for the response 2.0, and this plan is looking at 3 different focus: the intensification of the response, especially on the hotspot country, the integration, and the legacy. So talking about the integration, we've seen in many countries that a good proportion of the suspected case of Mpox actually have measles. So to address that issue, we are doing many things. One is to ensure the syndromic approach at the level of the detection, pushing to have diagnostics that can have the multiplex testing telling us when we have a suspect, we should not only consider those who have Mpox, but also raise the alarm and say, if it's not Mpox, this is measles happening. And therefore, we can implement the adequate response. We can also implement the case management and the IPC. And that is part of the legacy that we want to leave in the exposed countries. Over to you, Dr. Margaret.
Thank you very much. Let's take the next two questions. We have Zainab from Affinity. The question is, given the critical need for the Mpox vaccines, is there hesitation around deployment of the Japanese Mpox vaccine? That's the first question. Let's take the next one. We have Michael Guarisa from Health Times of Zimbabwe. Looking at the DRC, how successful have the contact tracing efforts been, given the numerous challenges facing the country? There have been reports of Mpox patients who fled a treatment center a few weeks ago. What were the efforts to trace them successful, and did they receive treatment? And how many patients fled from the treatment center? Over to you, Prof. Yap.
Thank you so much, Zainab, for the first question asking about the Japanese vaccine, the LC16. So this is a bilateral partnership between the Japanese government and the government of DRC with support reaching 3 million doses of vaccine that are planned to arrive in DRC. So far, 50,000 of those have arrived. A training have started. And last week, there was a delegation of the Japanese government and the Aid Fund to come and discuss with the DRC how they are going to implement. So there is no hesitation at this point, but rather a need to have the proper planning, preparation, and to ensure that it's done adequately. For the question of the contact tracing, that's a very good question. I mentioned that we have 2 suspected cases out of 10 who are actually tested for Mpox, which means all the other are not. And they are not mainly because at the community level, the tracking is not properly done. So what we are planning to do, what we are actually started in Kinshasa, is to intensify with the deployment of community healthcare workers. When they go in the household, they go with the different map of pictures of the Mpox so that they can, 1, share the information, 2, look for people who are having those symptoms. So when they have those suspects, they can now raise what we call an alert. And when that is done, they can take the sample with the support of the district, send to the lab, get the result, and around the positive case, then they will do the contact. They will tell the number of contacts that are around the case. The average, the target is 20 contacts per 1 case. In the beginning, we were having around 1.7 contacts per case. This is what we were having in DRC. And that's also one of the reasons why the strategy to vaccinate among contacts could not work, because we are having 2 small numbers. Now that we are intensifying, we can see an increased number of contacts. Last week, the Minister of Health was presenting around 10 contacts per case, which is already an improvement, and which can actually give us some positive sign that if we keep the intensification, then we may be able to have a highest number. But again, Mpox with the clade 1B is sexually transmissible. Yesterday, the incident manager from Uganda was telling us, you have a sex worker that has 10 clients per day. She has no clue about who those people are. How do you trace them? So in one side, we do our best to get all the contact whenever it's possible. And in the other side, through the communication and risk engagement to all the different pillars and action, that's how we will have a consolidated, a comprehensive approach to control the outbreak.
Thank you, Prof. Let's take the next 2 questions. I have one here on the measures in place to ensure that people living with HIV presenting with a symptom or two are further investigated for Mpox? And are there any prophylaxis for people with comorbidities such as PLW-HIV, as is the case with the TB, with the fight against TB? And then I have another question here on something on the vaccine as well. This is from Mariska. The question is there an update on the vaccine trial against Ebola Sudan virus, given that the dose is a 2-dose regimen? And how is that going? You can take those two questions, Prof. Over to you.
Thank you. So we did mention that indeed, especially in Uganda, the high case fatality rate was happening mainly in people having comorbidity, including HIV. So what they are doing, to ensure that the program managing people living with HIV is integrated in the response. And based on that, they are adapting and adjusting the protocol to manage Mpox and HIV. That's also one of the support that they request to Africa CDC, and in the team that will be going to Uganda in the next few days, hopefully, we'll have the case management expert. And their role will be to see how to prioritize, how to adjust. Which one do you start? Is it HIV? Is it Mpox? How do you be able to have the two treatment at the same time? Same thing in Uganda, in DRC. Last week we were having the director of the CNLS, the organ that is managing HIV, and they are doing the similar approach, ensuring that there is an integration, both at the time of the advertisement, the communication, the community engagement, but also on the side of testing and treatment. So on the question of the vaccine trial, I will hand over again to Mosoka.
Thank you. It's early to tell the efficacy. So you know that they had the immediate and delay rings. Around 180 of the contact were placed in either of the two rings. So it's ongoing. But at least what we knew from the early stages was that in both rings, the rate of infection seemed to be similar, but it will be easy to tell. So we know, of course, there are no new cases, at least for a couple of days gone by, but the data is being analyzed for sure. We know that 180 contacts were enrolled in 12 different rings, and the rings are being followed to see those that got the vaccine early and those that did not get it delayed, to see the rate at which infection will happen. So the best answer is it's too early to tell, but we now have a good, well-established pharmacovigilance, because that's another objective, to look at the safety. So the safety profile is being monitored as well. So too early to tell. Thank you.
Thank you, Papa. There was a question that I've not fully answered about the patient that fled out from the Eastern DRC. There were more than 600 positive Mpox cases that are fled out of the center. 160 came back and was the treatment continue. But for the other, we don't know. We don't know. And what we are doing is strengthening the involvement of the humanitarian actors. We've been talking about the corridor, humanitarian corridor. Next week, for example, MSF is going to come to IMST to present what they are doing on the ground and how we can strengthen their collaboration and use the fact that they're on the ground to track those patients, and then to see how we can get them all and ensure that we limit the spread of the Mpox transmission in those countries. Over, Margaret.
Thank you, Prof. The next question is from Pedro Alonso, who works with the Spanish news agency in Nairobi. So the question is, your figures show today a cumulative 1,709 deaths for the continent, and also 1,709 deaths across the continent for DRC. So the question is, I understand most deaths have been recorded for DRC, but not all of them in the continent. Please, can you clarify that? I'll hand it over to you, Prof.
Yes, I will give to Dr. Mercy to answer that question.
Thank you so much, Prof. So indeed, all the deaths that are among suspected cases are from DRC because they are that's the country that is facing the biggest challenge in terms of testing all the cases. So the deaths that we see that is the 1,709 deaths among suspected cases. And if you look at the left where you have the deaths among confirmed cases, you have around 100 deaths among confirmed cases.
And the high numbers of deaths among the suspected case also highlight the question of those people dying. Are they dying only from Mpox or for other disease, including measles? That's why the integration approach is so critical to ensure that we can have an early detection of measles, chickenpox, and those other diseases that will cause some death, and sometimes even more than Mpox.
Thank you, Prof. The next we have Meron from Ethiopia. Importance of in address like Mpox and others in African countries. And then the other question is about what modalities do we have in place to control transmission of public health emergencies between countries? Over to you, Prof.
Okay, I will answer the first question, and I will let Dr. Mercy talking about the transborder surveillance. So definitely, we see those outbreaks, Mpox, measles, as a medical issue. But when you go to Pakajuma, I will take that example, which is in Kinshasa. This is a slum. So you have those sex workers. This is their activities. So to protect them from spreading or from getting Mpox, you cannot just have a medical approach. In Uganda, for example, they propose to provide some incentive for them to stop their activities for 1 week or two so that we can stop the transmission. But that did not work, which means that we cannot solve those outbreaks only looking on the medical as the scientific side. There is the social side. We are talking about a sexual network. It in parameter coming out of the medical. That's why we have all those 10 pillars to respond. And some of the key pillars is the risk, communication, and community engagement. How we communicate to the community so that they own the rest behavior and ensure that we limit the spread of the disease. So definitely it's a multifaceted approach. Now, when you consider, we consider the crisis in eastern part of DRC, when the patients are flooding out of the treatment center because of the crisis, it has nothing to do with health. It has to do with peace. So therefore, we have to work with the humanitarian, and we have to work with our leaders so that they can bring peace. And then when peace is there, we can be in the better position to control those outbreaks in our countries. Now, on the side of the second question on the cross-border surveillance, I will let Dr. Mercy.
Thank you so much, Prof. and Dr. Margaret. So actually, falling back on the IHRO that looks at urgent resilience structures and institutions in member states so that they are able to detect, prevent, and respond to public health threats promptly without actually having any impact on trade and travel. I mean, that's the foundation of now public health emergencies in terms of response and preventive measures. In that light, one of the key measures that we put in place to ensure that each and every country have all these different core capacities that will permit them to detect and contain at source without it spilling over the borders. And we are putting in place early warning systems, event-based surveillance systems where countries are able to detect public health threats promptly. The second thing that we're doing is ensuring that we have data sharing mechanisms or information sharing mechanisms, and we've established a number of coordination structures that countries are able to convene together and share information promptly. Some of them include community of practices where countries come together, share information on public health threats, and also alert their counterparts on public health threats that are currently happening within their borders. The third, which is also very important, is establishing cross-border coordination mechanisms, in the sense that so far we have structures that might not, or in some countries might not, that might somewhat inhibit or slow down on timely exchange of information across borders. It could be legal structures, or legal instruments such as data sharing instruments that are not in place that might not really support information sharing. So one of the things that we're doing is to set up this kind of frameworks where countries can easily look into and establish this kind of coordination of information sharing frameworks. And for instance, there's an ongoing planning for a multi-country engagement that is being championed by the World Bank in collaboration with Africa CDC and WHO, and that is planned to happen sometime in May, whereby we are convening all the countries that border DRC. And one of the critical areas we are looking at is establishing this kind of instruments, like memorandum of understanding between DRC and the neighboring countries to facilitate information sharing. And countries have actually agreed to get into those negotiations and agreements. And this is within the framework of the Mpox response, but again, it's gonna be utilized for other ongoing public health emergencies. But of course, Mpox is the entry point to this convening. So these are some of the things that we're doing, and definitely, because of time, we might not be able to share everything here. But if you want to learn more about our efforts, you could also see within on our website on our cross-border initiatives, especially within the Mpox fund. Over.
Thank you very much. We have another question here for Dr. Marcy. Can you please provide more context on humanitarian corridors' role in delivering healthcare in Africa? And then we have another one here that talks about the sensitivity. Is there any sensitivity to the Mpox molecular tests that are currently in use? Over to you, Dr. Marcy and Prof.
Thank you. I'll be starting with the second question and then come back to the first one. We currently have our lead of the Diagnostic Advisory Committee of Africa CDC coming to follow up the evaluation of the rapid diagnostic test. We know that if we have those tools, they can really be at the lowest level of the community. And within 15 minutes, we will be able to have the answer, whether the person is a suspected case or a confirmed case or is negative. So the evaluation is ongoing. We have two tests that are quite advanced in the evaluation, and we hope that in the next weeks from Kinshasa, they have the green light to go back and work in the Kivus, the North Kivu and the South Kivu. But now the health workers who are in that site, because the environment is still occupied, they might not have the authorization of the occupant to work with those ones. That's where the humanitarian come to play. MSF, ALIMA, WHO, and all those who are on the ground, because they can have access to the patient, they can be in the health facilities, but we also want them to be in the community with the community healthcare workers. So while the actual corridor is being established, we are expecting that to allow us to move with the member state. But in the meantime, as IMST, we support all our partners so that we keep on pushing the activities. The vaccination, for example, we hope it to resume in the Kivus. There is around 20,000 doses in the South Kivu. The country has received 69,000 doses of Mpox vaccine. So the aim is to move to South Kivu because that's where we have the highest burden of Mpox so far. but that will happen only if we rely on the humanitarian actors and all the networks to make it happen.
Thank you, Prof. We have, I think Dr. Massey was supposed to answer the question on the humanitarian aspect of public health.
Yeah, I think Prof has just answered the question about the humanitarian corridor, which just as a mechanism that has been put in place during armed conflict that will permit humanitarian actors to actually descend and be able to do the work, and also as a passage whereby we can also have logistics, you know, and other supplies, countermeasures, get access to those who need the most during this crisis.
Thank you. There's two more questions here. We have one on the Pakajuma campaign that was took place in DRC. So the question is, how many children were vaccinated and what is the next step from there? And then the other question is on the second phase of the IMST and what are the expectations there when it comes to, you know, the partnership on the ground and what is expected to be covered as well. Over to you, Prof.
So I will start with the response on the second phase of the IMST, while my colleague, Dr. Charles, will respond on the proportion of children that were vaccinated in Pakajuma. So we've learned a lot from the first phase, the first 6 months of the IMST response. In December, we have the intra-action review where we have all the member states as hotspots sitting there together, trying to understand what were the best practice and what were the area for improvement. And at the end of it, we agree on what were the immediate action, the immediate action, and the long-term action. So those were translated now in the response plan 2.0 with the intensification, which is what we need to do now in the most affected country, talking about DRC, talking about Sierra Leone, talking about Uganda. Burundi is doing well. We're still monitoring. Next week, there will be a training on decentralization of the laboratory to keep emphasizing. And that kind of activity